Thanks for joining us today. Looks like we had a number of people sign up, so we're really excited to be presenting this afternoon on community assessment in North Carolina. I want to remind everybody, this is part of Engagement Week. So this is first ever Engagement Week, and today is the first day of that. So thanks for coming to our session, and just want to remind you, if you haven't already, to check out the website for other events this week that you can still join as well. And our agenda for today, we're going to do a brief introduction to the North Carolina Institute for Public Health, and specifically our community assessment and strategy team, which does community assessment work across the state and even a little bit across the United States. And then we're going to go into kind of community assessment and what community assessment really is. And then specifically talk about how community assessments have been going on the past 2 years in times of a pandemic, and how that's changed the way that we and our partners have had to approach community assessment. And as part of that, also talk about like some of those lessons learned from that time, and what things we're taking into the future and which ones we're happy to leave behind in the pandemic. And then lastly, we just want to talk a little bit about connections we can continue to make across the UNC campus and with other partners across the state with community assessment type work. So I want to start by introducing you to our team. This is, if you can tell, this is, I think, the first time our full team got back to in person after we started working remotely in COVID. We had a little get together with a couple of people moving on to some other opportunities on the team back in December, and we were obviously really excited about it. But we are part of the North Carolina Institute for Public Health, and so we are embedded at UNC Gillings. We're an institute within the school, and we use the expertise of staff at Gillings, as well as faculty and students and our partners across the state, to train, coach, convene, facilitate, all those good things in order to improve public health practice across the state, whether that's developing leaders, transforming organizations, specifically our team, translating a lot of data to impact, but most importantly, building capacity for our partners to be able to do more for the health of their communities, so that they in turn can support thriving, healthy communities right where they live. And so it's a really cool, we're kind of this bridge between Gillings and our practice community across the state and kind of beyond. And so our mission is really to facilitate collaborative solutions across our state. And specifically, kind of one half of our group, we have a workforce development section or side of our house at NCIPH. And then we have our community assessment and strategy team. And this team does a bunch of different things, as you can see here, a lot of data collection, but not just the collection and the analysis, but a real emphasis on the interpretation and visualization and messaging, also strategic planning, GIS mapping. But specifically, as we're going to talk about today, community health assessment and improvement planning is a strong part of our work. And really that's to impact our audience, a lot of the clients that we serve across the state, our partners, lots of times local health departments, the state health department, nonprofits who do public health related work, hospital systems, healthcare systems. We have a lot of different partners, philanthropy also. And so we have a really strong team. This is our community assessment and strategy team as it exists now. A couple of us have been here for a while, and then we have some people, actually, if you look at all 5 on the right-hand side, all came during the past 2 years of the pandemic. So I can't say that the pandemic has been all bad, because we've been able to add to our team in some really wonderful ways. But we also want to acknowledge some other members of our team who've been a big part of developing our community assessment work over the years. Matt, Aaron, and Elizabeth, who used to be part of our team. We also, because we've had so many projects lately, have brought on a team of temporary staff, as well as Joe Dawson, who does our digital communications as a part of every project. And as part of our mission, one of the things we love to do is work with students at Gillings as well, and introduce them to working with practice partners across the state. So we have many students who've engaged in our community assessment work this year. And so this is just a brief snapshot, and we can provide this to anybody after who wants to kind of dig into this a little bit more. But we also pride ourselves in kind of how we do data collection and analysis and interpretation, and how we work with community partners in doing that in ways that are ethically sound and kind of the right way to do things. And so again, be happy to share these after, but just know that we are kind of guided by these principles and practices in our work. And not only in using data, but kind of our approach to collaborative work. We really feel it's stronger when we're engaging multiple partners, and we use these guidelines now to help inform the beginning of our work with partners. And we ask them to hold us accountable to these things, as well as we like to check in with them from time to time when we have concerns about certain pieces not being met. But it really frames the way that we do our community assessment work. So with that, I'm going to hand it over to Margaret to talk about community assessment overview. And I think I forgot to say earlier, but we are recording. Just wanted to let everybody know. But with that, Margaret, would you like to talk about community assessment?
Yes, thank you, Amy. Good to be with you all today. So I'm going to give a really brief overview of the community assessment process and kind of ground us in why we even do this work. So since 2010, our team has actually worked with 40 different counties at some point on the assessment process. And Amy, if you switch slides here, we can see a map there. Sometimes we help counties through their entire process, kind of from start to end. Other times we're working just with data collection or just with analysis. And so our involvement varies across the state. But the assessment process, at least in a public health context, assessment is one of the 3 core functions of public health. And through this assessment process of assessing and monitoring population health, really to understand health needs and those root causes. Together, that helps us going through that process as this collaborative approach in the community health assessment model, helps us identify community issues that the whole community can really stand behind, and helps us think strategically rather than reactively in the years to come. And so the community health assessment itself is a part of an overall improvement planning cycle that takes place every 3 to 4 years in every county across North Carolina. And so you complete your community health assessment, you determine a few key priorities, and then those priorities is what guides your improvement planning cycle for the following 3 to 4 years. In North Carolina, there are kind of 2 main requirements that guide this work. The Affordable Care Act requires that not-for-profit hospitals complete an assessment every 3 years, whereas the North Carolina Local Health Department Accreditation Program and the State Health Department Consolidated Agreements require that health departments complete a cycle every 4 years. So many counties have taken a joint approach and they together complete a cycle every 3 years, but some of our counties stay on a 4-year cycle. So in doing all of this work, counties can get a better understanding of community strengths, needs, concerns, interests, really by talking to community members. Throughout the assessment process, we're not only looking at secondary data that already exists, but we're also directly surveying, directly asking community members and holding community conversations to hear what those needs are. This also helps us explore root causes. We're not just looking at a percentage and drawing some conclusions there. We're having conversations and kind of digging down a little bit deeper, which helps us be intentional about how we design the next step, whatever happens next, and thinking intentionally about what resources exist, where do we need additional programming, additional resources. Also, just through the assessment process, a lot of partners come together and kind of get a common understanding, a common purpose for the years to come. So going through this whole data collection, data analysis, and prioritization process helps us see all of these partners getting a common understanding, common language, and really drawing new partners to that table to get engaged in that improvement planning work that comes afterwards. So the assessment process itself is very thorough and lengthy. We prefer this take at least a year. Sometimes we don't have that much time due to those state requirements. But we've kind of broken it down into 8 phases on the slide. I know this is small. We're really only going to focus on 2 of them today, but to give you a really quick overview, if we could actually go back to see all of them. We establish a team. We try to get a lot of different folks involved at that table, engaged in the process. We collect both primary data through surveys and also through discussions, through focus groups or community conversations. We're also collecting secondary data that already exist. We analyze and interpret all of that data together, and that informs a prioritization process. From that, we create a formal report that we then share widely to inform that action planning process. Community should be engaged at every phase, at every step of this process. But today we're really going to focus on phase 2 and phase 5, because this is where we are engaging the masses. We are calling everyone we can reach to really participate in the process. And this is where we've had to pivot a lot and change a lot due to COVID. So I'm now going to pass it off to Allison to talk a little bit more about that primary data process.
Great. Thank you, Margaret. And thank you to everyone who's here today. Next slide. So Margaret covered this a bit, but there are two primary ways where we often collect primary data in our community health assessments. One way we go about this is through a community health opinion survey. These surveys can be conducted in person, by door to door, online, or over the phone, or even by a combination of these methods. And we will talk a bit about the pros and the cons of these different approaches in a moment. But the goal of the survey is to try to collect data that is representative of the county, although this can be very challenging. Another way we collect data on community is through small group discussions. This could include listening sessions or focus groups, and these are generally best suited for collecting qualitative data. For community health assessments, we often select groups based on different priority populations and then set up separate focus groups for the different groups. And Rose, in a couple minutes, will talk some more about this. Other approaches to primary data collection include key informant interviews or structured conversations. These are conversations with people who have specialized knowledge, like providers or caseworkers. Another approach is asset mapping. This is a process of identifying the resources or assets in the community, like services, programs, sources of funding, and others. And these help identify strengths and can establish a link between health needs and interventions or solutions. Going back to the community health opinion survey, I'm going to take a couple slides to talk about this. At NCIPH, we generally structure a community health opinion survey to include questions about subjects ranging from health status and access to care, to community issues, assistant needs, and social determinants of health. We also try to collect information on demographics. We find that this is important because it enables us to better understand how well the survey population represents the full county population. And it also enables us to look at responses to see if they differ depending on demographic characteristics. We work on customizing these survey questionnaires with stakeholders who are part of each community assessment process, and this can involve balancing comments from many people with different interests. And it's become increasingly important for us to think about how to weigh these different wants and needs as we create these surveys without making them overly long and burdensome. And in addition, it's really critical to think about what the questions are that we have and how we ask them. And with all of this, we need to think really critically about how to identify the people to participate in our surveys. In terms of identifying people to take the survey, we often are left to decide between strategies that are easier to implement versus strategies that reveal better quality, more representative data. These are a couple different options for selecting a sample for a community health opinion survey. For example, let's say we have a list of all households in a county. We'll call this a sampling frame. This table lists 3 different sorts of sampling methods. Simple random sampling, this is where every household in this example has an equal chance of being selected to receive a survey. Cluster sampling, this is where we divide the population into geographically distinct groups or clusters and randomly select clusters of people to receive a survey. We can take additional steps to actually select households within each cluster. We'll get into an example of this in a moment. And a third alternative is convenient sampling. This is when we sample from the population that is most readily available to us. So we could post a link for a survey on social media or approach people at a community event to ask them to take a survey. This graphic further goes into detail on which sampling methods are better or worse. Options for a survey in regards to looking at cost, quality of data, ease of implementation, and representativeness and generalizability. And the check indicates that it's a good for that particular quality, where a check plus indicates the best option for that category. Simple random sampling will produce high quality representative data that can be generalized to the target population. However, simple random sampling is costly and really rather difficult to implement. Convenient sampling on the other end, such as web surveys, is cheap and easy to implement. You can get large sample sizes, but this method results in often the poorest quality of data. Whereas cluster sampling is used as a compromise approach because it is easier to implement than simple random sampling, and we're still able to assess if the data is representative of the sampling frame. In deciding between strategies, these are some of the questions that we might consider. What sampling methods are we using and why? How are we conducting interviews? Let's take a few minutes to go over each of these questions. Due to COVID, we've had to pivot our approaches to both sampling survey participants and collecting the data. Let's first take a few minutes to talk about how we sampled and participants and collected community health opinion survey in the pre-COVID world. So prior to the pandemic, our team typically did some form of two-stage cluster sampling and administered a survey by having trained interviewers go door to door with a tablet in hand. Here, a diagram shows the process of selecting a two-stage cluster sample, and we talked about this a few moments ago, but cluster sampling involves dividing the specific population of interest into geographically distinct groups or clusters, such as neighborhoods or families. And because this information is readily available in the United States, many people use census blocks or block groups as their clusters. In our case, this was done by starting with a random sample of clusters, and this we can actually go to the next slide. The team randomly selected a group of specific census tracts, and this is an example of what we've done in the past. The ones highlighted are the ones that we selected as clusters, and then the team selected locations within the census tracts for actually doing the interviewing. So there was 2 stages of sampling. And the team, in terms of collecting data, used CollectSmart, which is short for Survey Management and Response Tool, to help in collecting and managing data. The app works on an Android-based tablets and phones, and it allows for real-time tracking of the field team, and also enables the interviewers to easily track their progress. The tool is web-based, and it also allows survey site selection using US Census data. And the data is securely stored on the cloud and enables the project manager to actually track everything in real time. Using an electronic survey tool like this reduces errors and saves time compared to a paper-based method. And with door-to-door surveying, as opposed to an online survey, the team is more likely to reach folks that would not necessarily have access to a web-based survey. And now I will go and turn this over to Rose to talk a bit about focus groups.
Hey everybody, thanks for joining us. I'm Rose Burns. I'm the Qualitative Assessment Coordinator at NCIPH, and I'll be talking about the qualitative side of primary data collection. The purpose of conducting focus groups as part of the community health assessment may vary from project to project, and defining that purpose up front is an essential step. So sometimes you might want to fill gaps You might want to target focus groups to segments of the community who will not be reached by your community health opinion survey, for example, like people experiencing homelessness or people who speak languages other than English. And sometimes you may have a topic that may not be well covered in your secondary data that you want to focus on. And this is particularly useful with respect to emerging issues like COVID, for example, because often the secondary data available to you are a couple years delayed. And like we all know, a lot can change in a couple years. We'll talk more about that later. It's also a place where you can dive deeper into issues and get more nuance and context than you would in a survey. And this is particularly helpful for like health behavior issues, to be able to understand the drivers and barriers behind things like smoking or physical activity. So because of the immediacy of qualitative data collection and reporting, you're hearing people's stories in their own words. Focus groups can really deepen participants' connections to each other and to the organizations that host the groups, as well as the community health assessment process. And then on the other end, you are sharing people's quotes and stories, which can connect stakeholders and representatives from different organizations who you're eventually going to tap into as partners in making this change. Sharing these stories is a way to more sort of make that human connection to the work. As well as, in your report, sharing quotes and stories has an immediacy to it that can connect people to the data in a different way. So this is just an example of a guide that we might use in a focus group. The goal is to make people comfortable talking. So we start with like a round robin question that's pretty broad and low stakes, so everybody feels like they can participate. And then, we might have some pre-planned probes to make sure that we're getting the targeted information that we need out of this group discussion. And we're building towards some questions that ask people to think a little deeper about a topic. And we're always, because this, qualitative data collection is such an opportunity to hear from people about their strengths as well as the barriers, we do try and have a balance of the two. And this is really where we're able to get those opportunities that health departments and other organizations involved in the community health assessment, those opportunities where communities are already making progress formally or informally, opportunities to build upon the places where folks are already supporting health in their communities. So, excuse me. I will say that, the guide, just one other thing is we may have a really beautifully planned guide, but really, once you get folks in the room and started talking, that people often are going to share. It's really all of the engagement and pre-work that goes into making it accessible and having people trust the setting enough to show up and share their voice. And these logistics have had an extra special layer in the past 2 years with COVID. And with that, I'll turn it back over to Margaret.
So we're going to dive into COVID impacts, because if you haven't noticed already, COVID impacted our community health assessment process a good deal. And so we're going to walk through some main buckets where we saw some impacts and then kind of summarize some key takeaways. So first, with this opinion survey, we, as Allison mentioned, used to go door to door, but guess what? Health departments weren't that thrilled to have their own staff and volunteer go door to door to people's houses while also trying to encourage folks to isolate and stay at home. It wasn't a good look. It wasn't a good public health call. So we pivoted for our first time as an institute to fully online surveys. which we know are not as good. We tried as much as we could to make these work within our limitations during COVID. And so with this example, all residents were eligible and had an equal chance of being selected, more or less. I'll get to that in a minute. These questions can be pretty long, 30 to 60 questions, right? And when we're in person, you can get that buy-in, you can build that relationship, you can facilitate a survey. But when you're doing that online now, like that gets tricky. So we sent out some mail postcards, we tried to get incentives, we experienced some survey bot attacks. We learned a lot in the process. But if we go to the next slide, we can see kind of how we thought a little bit differently about our sample selection using this online approach. We selected 200 addresses from 8 different zones in proportion to the households in each zone. And then we actually complemented how many we selected with an additional 1,000 from the service zones that were least represented in the previous assessment cycle. This is something we might have done even in our previous typical cluster approach, but felt especially important when we were relying on postcards alone. And also, though, that means even more postcards getting sent out multiple times. So on the next slide, we can see an example of kind of our survey timeline. We were doing simultaneously this random approach where we were sending out postcards and trying to get postcard recipients to respond. And we also had a convenience survey open where anyone who wanted to fill out the link could. We started the random survey. We promoted the random survey first before we opened that convenience survey that was open to everyone, because we wanted to make sure people who had been randomly selected to receive a postcard had had the chance to see the postcard before they saw some ad on social media. And so we had to be really specific in our timing. So we sent out the first postcard, we sent out the second postcard, and then we opened that convenience survey and we started doing big pushes throughout the community. We then did a third postcard, and then we were planning to kind of close the random sample, close the convenience sample, and then analyze them kind of coupled together. We hit a lot of roadblocks getting responses. It's hard to get people to spend time answering an online survey and have people do that in a way that's representative. So we were tracking the demographics, we were tracking how many random respondents we were receiving. We ended up pushing out our timeline for over a month on this project. This project gave us the flexibility to do that. We were able to pivot and adjust, but not all of our projects give us that flexibility. So we learned a lot in this process. This was especially important because of some secondary data limitations. So we see in the secondary data across the board, there's always delays in data availability, right? So the data that's available right now is often data that's 2, 3, sometimes 5 years old. When you've had a global pandemic impacting everything for the past 2 years, our secondary data often doesn't even acknowledge the world that has existed during COVID. And so that created some real challenges because, you could look at trend data and say, oh yeah, uninsurance is trending down. And it's like, well, except a lot of people lost their job during COVID and the last available uninsurance data doesn't capture that employment dip that we saw during COVID, right? And so there's a lot of gaps. Also, even when we do have data during COVID, it's hard to interpret that trend data. For example, we look at diagnostic data. So how many folks were diagnosed with STIs, STDs? Is that because if we see a decrease in diagnoses of STIs, is that because people weren't going to get diagnostic tests as much because they were avoiding going to the doctor? Is that because people were changing their health behaviors to isolate from folks? What are the actual reasons why we're seeing that dip? So we have to really keep that in mind. And then also we had some issues with just how we coordinate on what data to include. That was a lot harder when we were existing in a purely virtual world. Rose is going to talk more about this in a second with our steering committee, but when you're sending giant lists of indicators in an Excel document to your partners, and you don't have that face-to-face meeting to kind of walk through those details, I can screen share a giant Excel sheet, but that's intimidating. Or I could go to go to an in-person meeting and really have a conversation, and it feels a lot more accessible. And so we had to pivot a lot to have those conversations in a meaningful online way. And now Rose is going to talk through some extra limitations.
Yeah, related to our focus groups that we've conducted in the last few months, I'm going to give the example, one example of the work we're doing with Granville Vance Public Health, which is a combined health district north of Durham and Wake counties, which includes Oxford and Henderson. We opted to conduct these focus groups in person this fall, in fact, because we didn't want to lose the benefit of doing those in person. And I don't know if you remember, there was a brief period where things seemed a little bit hopeful this fall. And so we ended up, doing in-person focus groups, but without some of the normal things that we would do, in the before times, like offer a meal during the focus group, offer childcare. And, so we were coming together. It was a little bit more, sterile in a sense. We're all wearing masks and keeping some distance, but we were able to do that in a way that, kept the public health precautions, but preserved that in-person aspect. So I'll show you some of the demographics there of the people who showed up. So we had 78 participants ranging in age from 16 to 79 in these focus groups. Because youth were a priority population, you can see in the age distribution that we had a big bump there. We also prioritized Spanish-speaking communities, so and those with barriers to service. So you'll see that our participants were predominantly identifying as African American and Hispanic. The participants were about 2/3 women and girls, and this is something that we often see in focus groups. And a note here that we had really fantastic representation from Black and Latinx communities. And I will credit our community partners who are really doing deeply community engaged work up there, and have built that credibility and trust needed to bring folks in for this kind of discussion. But I'll say that this kind of turnout comes with a responsibility, right? So Black and Latinx communities can often feel over-surveyed and over-assessed. And if there's continued assessment without action, and without those feedback loops of this is what we heard, this is what we're doing with this information, this is how you can continue to engage, this can actually be an opportunity to burn bridges rather than build them. So I'm really proud of the turnout here, but also, recognizing that responsibility that comes with that. With our steering committee, this, as Margaret identified as the, first step of the community health assessment process, they're a key part. And while their role of connecting people, serving, representing marginalized perspectives, giving input on key decisions, their roles are the same. The way that we have had to interact with the steering committee has changed. And, as you know, having a remote meeting makes participation easier for some folks if they don't have to drive to another city, which is maybe 45 minutes away, or negotiating other responsibilities. So in some ways, participation can be easier. But, you lack that in-person communication and those bonds that are built between people working towards the same goal, the chit chat after the meeting and on breaks of like where their work aligns, you miss a lot of that. Also, people on the steering committee are chosen because of their role doing direct work with communities, organizations and health systems. And guess what? Those are the folks who are then called upon to rise to the occasion in their communities during a public health crisis. So when we're asking people to do things to engage their communities, they're also being asked to engage their communities for vaccination drives, for dealing with the Omicron surge that totally upended our plans for doing in-person focus groups in Wake County, for example. So all of this, there are pros and cons that come with conducting this work in a pandemic. Next slide. So as we see, COVID has touched all aspects of our life, affected all the systems that we rely on in society, but also for conducting community health assessments. And we've all had to adapt and grow to meet the moment. Which leads us to our lessons learned. How did we grow to meet the moment? And what would we do differently next time? I'm going to talk about, we'll talk about sort of three components here: community voice, in-person surveying, and outreach and promotion. Everybody's voice counts. If everybody is heard, everybody is important. This is a quote from a focus group participant from one of the focus groups we did this fall. People are dealing with a lot right now. And also people's voices and influences in this process is essential. And it's how people are heard and counted in this moment when we need deep community engagement and influence in these processes. It was reinforced for us repeatedly that we need to engage with our partners in multiple ways and allow enough time for people to engage with us as they're able. So one example of this was with our partners in Wake County. We started with a conversation about who they wanted to prioritize for focus groups. And when we realized that it was hard to get to decision-making in that Zoom meeting setting, we then deployed a quick survey, and that's what you're seeing on the screen here, to get a temperature check from everyone about what groups they'd like to prioritize. And then next slide, then we facilitated an interactive meeting led by Margaret, who's a wizard in mural boards, which is the platform that we used for this, to really hone in on those priority groups and arrive at some decisions that everyone felt good about. This process took a lot longer than we expected it to, but I would say because we took our time and were able to hear from the steering committee and fully involve them in the decision-making process, when then they were called upon to mobilize their networks, they were perhaps more willing participants in that process. And I'll turn it over to Allison to talk about door-to-door surveying. Oh, you're muted.
Thank you. Thank you, Rose. Other lessons learned. We still feel that door-to-door is the best surveying approach. Why do we feel that it's good to take the extra time and effort to go door-to-door? This is the approach we feel is most accessible to everyone in the county and giving everyone an equal chance to participate. We also feel that this approach can give you the best response rates. People are less likely to turn you down if you are at their door. You are also more likely to get complete data, so less likely for people to skip over questions. And higher quality of responses with someone being able to be there to provide clarifications and explanations to wording. Lastly, it's really a boots on the ground approach that allows you to show in tangible ways what your health department or hospital is doing within your community and that they truly care about the residents. And this in turn can help improve the public image of your organization. We also advocate for using probability-based sampling as opposed to convenience. Here is just one example. in this case, there was a cluster sample survey and a convenience sample survey that were conducted in the same year in a North Carolina county. And those are those two middle columns. And then on the right side is a column with the demographics of demographic estimates of this county from the American Community Survey, which is a census survey from the same time period. As you can see, the demographics for the cluster sample and the county census estimates are quite close. You know, and we want the sample to be close to the census county estimates. And then going on to the next slide, looking at that comparison between the online and paper convenience survey and the county census estimates. Sorry, and yes, in the county census estimates, you can see that those don't match up nearly as well. And you can also see that with females and whites, females and whites were overrepresented in the survey compared to the general population. Likewise, because the survey was sent via email and mostly through a large employer, well-educated respondents were highly overrepresented, which presents a strong bias when trying to represent the voice of the overall population. So here, for example, it's looking like 68% of the people responding to that survey had a bachelor's degree or higher, when in the overall county, it was closer to 19% having a bachelor's degree or higher. The representation that was seen in the survey was not really surprising. Research shows that online surveys are biased towards women being more likely to complete them. Generally, people who are more highly educated and white have higher, more likely to complete these surveys. And part of this likely has to do with access to internet. In this case, this example we just showed, the convenience survey was also far more likely to have access to internet compared to the cluster sample. And the cluster sample was far more similar to the estimates for the US Census population, with about 70% of the sampled households having internet access. So all of these point to how important you know, your sampling method can be in getting data that represents your county and represents the opinions and wants and needs of the people living within your county. And with that, I will pass it back to Rose.
And so the final lesson learned is just taking multiple approaches to all aspects of data collection and engagement with the steering committee. Beyond the example that I shared with the steering committee, we also, you know, developed some ways to reach out to groups through every possible way that we can in promoting the survey. You can click through, so just promoting the survey, creative ways of launching this on social media. Thanks to Joe Dawson, who's on the call here. And, you know, eye-catching handouts and flyers, QR codes that folks can scan while they're waiting in a waiting room, for example. And so these are some things that even as in-person data collection becomes more accessible, hopefully we'll probably take some of these lessons away of how to engage. And with that, I'll turn it back.
Great, thanks. So we just want to wrap up by thinking those are some great lessons learned. I think we've yes, as Margaret says, we've become bot detectors. We figured out a lot of things that we never thought we would do in community assessments. But, you know, I think going back to those lessons learned, there's the tried and true public health methods we know that work. And then, we adapted in the pandemic and we had to, and some of those things worked and some of them didn't. And some of them will carry forward and some we won't. I mean, I think a lot of our work around the postcards and things like that was something that was built on a strong methodology, but that what we got in participation is still not as good as that door-to-door sampling. And so kind of reinforces for us some of the things that we were doing really well before, and some things we may need to get back to. But specifically, just wanted to wrap up by talking about potential for connections even further across UNC. And so I say here that community assessment is community assessment. So we've talked a lot about community health assessments today, and because we do a lot of those community health needs assessments or community health assessments, whether you're a hospital or a health department, or requirements for them. And so when you think about our state and 85 health departments and how many hospital systems, a lot of requirements out there for those. And so we do a lot of those. My team's going to roll their eyes at this, but we're currently doing 9. So we've talked about some like Wake County and Greenville Vance, but we're also working in Pender County and New Hanover. And we worked in Gaston and Rowan this year, and a bunch of different places, as well as in Ohio, if you can believe that. So a lot of needs for community health assessment because they're requirements, but you can use these exact same methods of primary data collection and putting that together with secondary data and prioritizing things and needs in the communities as a basic community assessment. It doesn't have to be a community health assessment. It can be in general about the community. And so other organizations like United Way, Smart Starts in early child education, a lot of different entities do needs assessments. And so the tools we use and the process we use can definitely be used for much more than just the public health field. And so Collect Smart, the tool we talked about, is a really awesome free tool that can be used for more. And we think it's really important too, when you think about this, to think about survey fatigue. It's really big in communities, especially when people have other pressures. And so one of the things we try to do too is really reinforce collaboration between entities. So Margaret mentioned it before, but we see a lot of collaboratives between hospital systems and communities or local health departments to do assessments, which makes a lot of sense, right? Combining efforts. We've also seen some new approaches, like in Chatham County, where they're using a cohort-based approach. And instead of kind of tracking trends over time, like we think of in a normal cohort design, what they're doing is keeping their population over time to survey every year instead of every 3 to 4 years. And actually, during COVID, that sample that they had, that cohort they had already established for their community health assessment, was used to do some seroprevalence studies for COVID. It was the only study in the state that had a representative sample, not a convenient sample. So a lot of reasons that kind of community assessment can go beyond just the health assessment part. But definitely working with other organizations and taking that approach makes the most sense. And it's a great way for students to get involved. We love for students to go out into the field. Rose talked a lot about the importance of hearing people's stories and connecting during focus groups, but I've been on field data collections as well. And I can tell you that I'm an introvert. So me going door to door and knocking on people's doors and talking to them way outside my comfort zone. But I've been in communities where I grew up and have done that and worked in organizations there. And you hear from people that said, nobody's ever asked me what I thought. Like, I just love that the county or whoever is wanting to hear from me. Nobody ever knocks on my door and asks me. And I've seen community partners say, I thought I knew my community, but I don't know all of my community. And so it's a great way to connect with the field data collection too. And it's a great way for students to get out there and see community as well. And so we would love anybody either listening live or may see the recording later. If you're interested in community assessment as part of research or practice, to reach out. Any other UNC schools or other public health programs or nonprofits or people outside of public health. Like I said, community assessment's community assessment. And so we're really, happy to engage partners in different communities who are doing this already and looking at ways that processes can be combined and better used in the community. And so with that, I think we're happy to take any questions. Feel free to come off of mute and ask any questions or any comments you may have. And while I'm waiting
I have
for
a question.
Yeah, go ahead.
My name is Rakaya, and I was curious to know if you all have any publications or like write-ups about your process that folks like we could share with our teams. This was a really helpful presentation, and I feel like more folks should know about it.
Yeah, we've got some old ones. So we are a different sort of team at the Institute. We are very practice-based, not so research-based. And so we don't do a lot of publicizing. We need to do more. We need to do more publication, but we get so busy in our practice work that we don't do that as much. But Rakaya, we've got your email through registration. I'll be happy to send you some things that we do have. Absolutely. And while we're waiting for more questions, just want to just remind everybody about Engagement Week. And also Rachel has put a brief survey in the chat there. If you can respond to that later. We appreciate you filling that out, both for the Engagement Week people as well as our group. But yeah, any other questions or comments? And Rakaya, what group do you work with? Be great to hear.
Yeah, well, me and Margaret were fellow HBs, and now I work with Abacus Evaluation,
Gotcha.
which is within the Center for Health Equity and Research.
Rose and I are working with Abacus, Lisa, on a project right now. So
oh, awesome.
You're our people too.
Yeah. Well, I did have another question if no one else has. So when it comes to the prioritization piece, how do you all, I guess, reconcile? Did you come across like challenges of different maybe priority populations having different priorities or needs or things like that? And how do you kind of determine for all of the community, you know, what becomes the priority that best represents everyone's needs and interests?
Yeah, so Wake County just had their prioritization work. Margaret, you want to speak to that?
Yeah, I mean, it's a great question and it's hard to do it perfectly. For Wake's process, Wake is tricky because it's huge and they have these different service zones. So they've done it before where they've tried to prioritize by service zone, but it gets kind of tricky because the county as a whole then picks priorities that they act on. And so we don't want to make, like, we want everyone's like smaller community's voice to be heard, but then if that voice is just going to be watered down and erased and like go with the net decision anyway, it feels kind of tricky. What we did in this cycle, so the opinion survey has some questions of like, what are your top health priorities? What are your top community challenges, right? It asks some of those ranking questions already. Those questions, we allowed you to filter them by service zone, by income, and by education, I believe. And we posted that on an interactive data dashboard that was open for anyone to explore. And we posted that along with a prioritization voting survey that we encouraged everyone throughout the community to respond to. We got about 2,000 responses throughout the community. That entire voting process was choose your top 3 priorities, what you would like to see the county prioritize, and also share with us your key demographics. So we asked for age, race, ethnicity, gender. That might have been it. And then we're able to then analyze that based on those demographic characteristics to see. We unfortunately were not able to do that in time for the community prioritization process. And so that community prioritization process took into account the previous opinion survey responses, all of the data we collected, and the group individual voting process. And there were 3 really obvious top picks across the county, but as we're writing the report, we're going to dig into those details a little bit further. And so even if something wasn't selected as the overall county priority, if it was prioritized in a service zone, that service zone county commissioner and manager can then focus on that kind of sub priority.
Yeah, and I wanted to say that in Wake, they've had a very, I think, genuine approach to prioritization and really using the community, the primary data and the secondary data to drive their prioritization, which is the way the whole process is set up, the way it should be.
Yeah.
That's not true in every CHA, and I hate to generalize, but lots of times some of the hospital systems, because they're newer to see the process maybe than health departments and the public health approach. But there is bias coming in sometimes to the process, and some people have in their mind before the process even begins what the priorities are going to be in the community, and so that you kind of have to look out for. And I think it's been interesting too. The team mentioned earlier about presenting just this gobs of data to people and how that's been more challenging remotely with COVID. You also kind of wonder if you do that in a multi-phase process, is the last data people see what's at the top of their mind when they get to prioritization, right? So that's been another tricky part of doing this during COVID too. Rose or Allison, anything else to add to Margaret's comments? Yeah, so I just want to point out that Rose put it in the chat. Oh yeah, Margaret put the Wakes Interactive Dashboard. Yeah, check that out. But also Rose put in the chat an old toolkit we used to have for CHAs. That's definitely our old one that you can check out, Rakaya. But I will note that we have a student doing a practicum with us this summer who's going to look at kind of a lot of lessons learned from our recent community health assessments. Our team regularly, not even at the end, throughout the process, we've been doing in the preparedness world what's called hot washes or after action reviews to see what's working, what's not working in this process right now, and have come up with a lot of ideas about toolkits and checklists and things to keep in mind. And so we have a student who's going to be working on that this summer, which is really exciting. Well, with that, we really appreciate you joining us this afternoon and wrapping up your day with us, hopefully. And please fill out the evaluation that Rachel put in earlier. But again, thanks for joining us and we appreciate it. Thanks.